Hello, everyone, and welcome to our forum this afternoon on nasal obstruction symptoms, causes, and complications, jointly brought to you by Mount Alvernia Hospital and Ascent ENT. I am Seema, your host for this session, and I'd like to thank you all for joining us on our FB Live now. In a few moments, we will be having Dr. David Chin join us to answer your questions on how to better manage underlying disorders. So feel free to drop your questions in the comment box, and I'll try to get them all answered today. Without further ado, let me introduce our expert speaker this afternoon and invite him on board to share the screen. Dr. David Chin is a senior consultant ENT surgeon with subspecialty focus in rhinology, endoscopic sinus surgery, and endoscopic skull-base surgery. Dr. Chin focuses his practice on the health of the nose and sinuses in both adult and pediatric patients. Additionally, he has a keen interest in surgery for the nasal airway and helps patients with obstructive sleep apnea. Hello, doctor. How are you today?
Hi, Seema. Thank you for the very kind introduction. Very good today, and a warm welcome to all our listeners in Singapore and Indonesia. Welcome.
Yes, it seems like we've got some regional participation today as well. So I would like to thank you first for joining us this afternoon despite your demanding schedule. I imagine it must be really busy times for you.
It is, especially when you're talking about COVID. A lot of people, when they have nasal symptoms, they are going to their GPs, they're getting tested for COVID. And I think people are just more aware of upper respiratory symptoms, and they're always worried about it. And actually, they're both ends of the spectrum. If we look back about a year when COVID was still emerging and we were still trying to find out what the typical symptoms were, there was a period where there was a lot of concern about people losing the sense of smell. And that actually became part of the diagnostic criteria for COVID at that time, because it was seen much more common than in other sinus diseases. On the other hand, because we're so good with social distancing and everyone's wearing masks now, we're actually seeing over the last 1 year a lot less sinusitis cases. And that means we're seeing those people who have chronic allergic rhinitis, and those are the ones that are emerging more and more these days rather than sinusitis.
Right. So, well, it's great that you brought this up because I was just going to ask you, actually, I often hear these two terms, allergic rhinitis and sinusitis, being used interchangeably. So how are they different? Because I hear sinusitis being used so often, but how do you distinguish them both?
So this is the biggest misconception that most people have, and when they come to see us, they often say that they've got sinus, and whatever language it is, it's usually the same. And I used to think this was just a Singapore thing, but when I was in Australia and I talked to our colleagues in the US, it's the same thing. Patients usually find it easier to use the word sinus to describe their symptoms of runny nose, whether it's runny nose, congestion, a nose block, a postnasal drip. It's all sinus to them. And I don't blame them, actually, because essentially it's just two nostrils. No one else can see what's inside. And I think this is a great opportunity for anyone who's listening for us to differentiate that. Basically, can we have a look at the slide one that we prepared? Mm-hmm. So if we imagine we're breathing through the nose, the nasal passage is just the nostrils going back to the throat, and it's like a cave. And at the side of this cave, you've got secret rooms, which are the sinuses. And here we can look at that.
There we are.
Cheek sinuses, you've got sinuses above the eyes, and you've got sinuses deep in the head. They're all filled with air when they're healthy, but they're only connected to the nose by very, very small, tiny holes. So those are the sinuses. So we differentiate the two conditions. When the condition affects the nose primarily, that's what we call rhinitis. And the most common chronic condition is allergic rhinitis, and you get sneezing, runny nose, and a blocked nose. And when it affects the sinuses, which are these spaces here, when the lining becomes thick, when it produces more mucus, when it becomes infected, that's what we term sinusitis. The symptoms can easily be confused, and that's why people need to come to see us. But essentially, there are different conditions related but different.
Right. Okay. So, because you mentioned the sinus, I mean, I've heard this growing up so much because, my brother, for example, gets up every morning sneezing away, and then, it takes him a good amount of time to actually recover. I've seen different people do different things. Some people go out in the sun, some people just let time pass. But what causes these early morning sneezes, and how could you prevent or treat them?
So that's typically allergic rhinitis, and it's estimated in the urban society like Singapore, at least 15% of people have some degree of allergic rhinitis. Could be more, could be less. I've had it before, I do have it. And so the first thing is what causes it. So it's our body's overreaction to an inhaled allergen. And the most common inhaled allergen in our region is actually dust mites, and many different types of dust mites. And basically what happens is that the dust mite allergen gets into the nose. We have built up an abnormal response to it. It triggers off the inflammatory reaction, and then you get the release of histamines and swelling in the nose, sneezing, production of mucus. And how long it lasts really depends from person to person. Some people have, it's all their immune response, how allergic they are. And also at different ages, you get a different response as well. We see the strongest responses in children, in teenagers, and then as people get into the 20s and 30s, they tend to get less of the sneezing and the runny nose, which makes them think that they've grown out of the allergy, but that's not always true.
So when they outgrow it, is it because their system has gotten better, or they've just built up a sort of they've built themselves up to outgrow it?
I don't think we actually know the answer to that, unless we follow a person from the time they're a child to the time they're 30 or 40.
Yeah.
My guess actually is that a lot of people, their symptoms change because there's a big group of patients in the 20s and 30s that we don't see very much. And then they come back later and the nose is all swollen, and now they're coming to see us because the nose has been getting gradually blocked over the years. And if I ask them what happened in the past, they would most often say that when they were young, they're sneezing and running nose and they thought they had outgrown it. I just think that the way it manifests changes over time.
Yes. And maybe tolerance levels as well, right? Like maybe you just sort of just don't pay attention too much to it at the older age.
Yes. And the lifestyle also affects how we experience our symptoms.
Yeah.
As an example of that, a lot of people say that, in the old days they used to say, oh, if you're getting a lot of allergy, don't go swim and do stuff like that. But for most part, I think if people participate in exercise, it actually mitigates and reduces a lot of the symptoms that they would get from allergic rhinitis, especially the obstruction. So
yeah,
there are
that's true.
many different factors that come into how people experience allergy.
That's true. So when do you think is when should people seek medical help? Especially when they are faced with the rhinitis, do they come at the onset, or do they wait it out and seek? I mean, look at monitor the symptoms first.
I guess I'd have three approaches to that. One, if you look at the international guidelines of how we classify allergic rhinitis, essentially it's classified as mild or moderate and severe. And when you look at the definitions for moderate severe, it really is when it starts to affect people's lives, affecting sleep, affecting the ability to work, or just a nuisance to them when they're trying to get their daily activities done. So that's when it becomes moderate or severe. So it's actually determined by the patient's own experience. That's one thing. I would have to say that in particular, parents of children who are primary school aged, that's an important time to start looking at it, because there's a certain period where I'll come to, we could talk more about this when we're talking about snoring and sleep apnea. But as our adult teeth start to emerge, that mirrors the time period that our jaw is growing. And this is one of those situations where if you don't use it, you lose it. Or a similar concept, if the nose is blocked during this crucial period of life from about 5 to 14 years old, the jaw just doesn't grow to its full potential. And so the consequences of that, not enough space for the teeth, so you get crooked teeth, got to fix it with braces and all that. And at the end of the day, you end up with a smaller amount of space. So you start your life as an adult life with a smaller amount of airway space, and that could have consequences down the road. So I think that's the other situation where it's important to address it early.
Yeah, I would have never correlated the emergence of adult teeth with your nasal passage, but yeah, that's very interesting. I mean, something that's often overlooked as well, I think, because the first thing people do is to try to resolve the teeth issues, and then they don't pay attention to the sinuses. There are lots of questions that are actually coming through our chat box right now. Let me just ask you. I mean, one of them has actually asked if surgery helps to treat nasal conditions.
Yes, surgery does have a role, but as with in all conditions, there are different. There's a different place for medical treatment and for surgical treatment. And I think for the nose, actually, it's become simpler and simpler these days. So, will surgery treat nose conditions? That's a very wide question. But we have surgery for the nose, for nasal obstruction, and we've got surgery for the sinuses. And I could say we probably have got four different things that you could target. So if the nose is blocked and the nasal, so let's look at slide number 2. Maybe that would help to explain things. So we're looking at a blocked nose, and the entrance of the nose is really, really important. Here it is, slide 2. So on the left side, we can see what an ideal nose is like. The green area marks the space through which we breathe. And in the middle, if you've got the nasal septum, it divides the left and the right side. And you've got the side wall, and you can see that round structure there. That's called a turbinate. It's a long structure that can swell with allergies and with infections. And so if you look on the right side, you can get a narrowed nasal space because the septum is bent. It's bent moderately or severely. And the other possibility is if the two side structures become swollen, especially with allergies. So surgeons are really just maybe plumbers, you can see that. So if the nose is bent and you want to equal it out, then you got to do surgery to make it straight. Now, you can't use medications for that. That's a structural thing. The side structures, you can use medications to control it to some degree if it's reversible. But sometimes if it's been enlarged for a long time, it's just more or less enlarged. And then you need surgery to make that smaller. So that's
right. So when we talk about, when we talk about medications, just on that point, because we often look at the often prescribed ones are usually antihistamines or nasal decongestants. But if especially with adults who are going to work, one of the comments that has come in is actually that antihistamines tend to make someone drowsy. So if you're going to work, obviously. Would you recommend taking a non-drowsy antihistamine, and does that sort of still meet the needs of? Does it really solve the problem?
Absolutely, definitely. For allergic rhinitis, we should be using non-sedating antihistamines. And the truth is that at least for the last 30 years, or if not more, there are very good non-sedating options, and we only recommend that for allergic rhinitis. So. If you're using a non-sedating one, almost always there will never be a problem. The thing about antihistamines is that they mainly target the irritated symptoms of sneezing, the runny nose, but in the long run, it doesn't really help the congestion and the nasal obstruction as much. So my advice is definitely if you've got allergic rhinitis, there's almost no place for sedating antihistamines. Those are reserved for when you're getting a flu, you want to go to sleep and you want to rest it out. Besides the sedative side effect, the old antihistamines also have a higher risk in regards to the heart and some other issues. They might be a small risk, but if you're an elderly person with a heart condition, then maybe we'd advise that you take the newer second and third generation antihistamines. And these can often be bought off the shelf these days, even from the pharmacy.
Yeah. Yeah. And with what about nasal decongestants? How do you recommend them?
If we're talking about allergic rhinitis, I don't think nasal decongestants are the treatment of choice, because if it's allergic rhinitis, especially in Singapore, it's not a seasonal thing. It's going to be there all year round.
Yeah.
And using nasal decongestants, it gives instant relief. I know that as well. So I use that for flu. But if you're using it every day, you can develop a tolerance to that. And it's almost like getting used to a drug. Essentially, if you're using this, there's a medical condition with a long name called rhinitis medicamentosa. Basically, a person has been using decongestants for a long, long time.
Yes.
The moment you withdraw that, instead of going back to normal, it comes back with a vengeance. It becomes even more swollen. So you're basically dependent on those medications. And that's not a long-term solution as well.
Yeah, because you develop a dependence. But I noticed that nasal decongestants usually tend to be prescribed for kids. Like I've had them for my babies when they've had allergic rhinitis or so, or even just a normal cold. Just wanted to find out, I mean, because we talked about kids earlier, I just want to bring that up again. How are these nasal conditions different from the kind of nasal obstruction that kids face versus the ones that adults face?
Oh, yes, very good question. So I think we can talk about in 3 age groups. Between birth and about 3 years old, we don't usually see allergy coming into the picture. It takes time to develop that sort of nasal allergy, maybe at the earliest 3.5, 4 years old. So in the early stages of life, usually the safest thing to do is to use saline. That's one of the good things to clear mucus and from the usual upper respiratory tract infections. And the decongestants can be used because you don't really have much else that you can use, and you know that you're going to use it for a short time. Now, if you move then into that middle child age group, that's when it's either a nasal obstruction can either be allergic rhinitis with the obstruction in front, but very commonly children also have an adenoid. An adenoid is the third tonsil. Essentially, we can look in our mouth, we can see our tonsils, and at the back of the nose in children, we almost always have an adenoid. Same lymphoid tissue. They react whenever they catch any virus, whether you've got a lot of symptoms or less symptoms. If we put a scope into a patient, we can see if it's inflamed. And sometimes if you get repeated infections, the adenoid just gets bigger and bigger. And so it is possible with children that the front of the nose looks rather clear, but you can see that the mouth is always open. They've got this that breathy sound, and that's because the adenoid is larger. Now, in general, by the time we reach our teens, the face is growing. Remember, we talked about how the face is growing, and the adenoids are getting relatively smaller, so there's less chance that the adenoid is going to block the nose. So that's a good question. In children, the adenoids play a role, and sometimes if it doesn't respond to treatment or it causes complications, then they end up getting an offer or a recommendation for surgery to remove the adenoids.
All right. Okay. Thank you. So, building on that question, I think, but this is not on kids actually, because we talked about nasal sprays. Someone's asked on Facebook if using a nasal spray gives headache. Are there any other alternatives? And then the same person has actually asked a second question about having a two-hole syndrome. So for a two-hole syndrome, does a post-nasal drip, is FESS the only way?
Wow. Okay, there are two very different questions
here. Different questions, yeah.
So let's say no spray giving headaches. My question is that whether the headache pre-exists
was already there, right?
Or it's only if you spray and then you get a headache. I think the first time, I can only say this, most nasal sprays don't cause headaches. Unfortunately, they are not without taste, without smell. And so sometimes the first thing that people, when you go swimming and you accidentally snort in some water, it hurts. And a lot of our nasal sprays and salines are designed not to do that as much, but it's natural. Anything unusual going into the nose is going to cause a reaction. The thing is, just like training in the gym, you can get used to it. I can spray my nose down and get all the benefits, and I don't get any of the side effects. But if you give someone the first spray in their life, it's never going to be pleasant. And I think maybe that's where the question is coming from, whether it causes headaches. I'd say it probably doesn't. We have thousands of patients on many sprays, and I can't say that it causes a headache. I think that's a initial.
But very
reaction.
often the nasal obstruction in itself can cause a headache, right? Like,
they can.
Yes. Yeah.
Exactly, and that's why I said whether the headache came before the spray. But
Yeah,
now
exactly.
I remember something else as well. It's also about how the spray is given, and a lot of people, because our nose externally has got this profile, they feel naturally that they should put the spray in this direction, and that's usually just going to make you not get the benefits and yet get all the side effects, because the nasal passage is actually horizontal, going from here towards the level of the ear. So we always advise our patients when putting the sprays to angle it more horizontally, and then they get less of the side effects.
Okay, that's a good one. And what about the second question? So this is about the two-hole syndrome. Is FESS the only way?
I'm not exactly sure what the two-hole syndrome is. Maybe the listener could clarify that. FESS is, I could come into that, but I don't think I can answer the question, because FES, endoscopic sinus surgery, is an umbrella term to describe how essentially we work through the nostrils using endoscopes, going into the sinuses, essentially to open these sinuses. Why we open up? Maybe we need to take out past fungal debris. Maybe we need to create access so that it ventilates better. Maybe we need to create access. So there are many different versions of VEST. The only thing that unites them is that we preserve normal structures that are required, basically the lining of the nose, and we work through the nose and we use endoscopes. So it doesn't sort of define exactly what is being addressed.
Okay, sure. Right. So, I mean, okay. The other question that I had about the nose before we went into talking about sleep apnea in specific, just to find out more about nasal polyps, because they tend to be one of the main causes of nasal obstruction, right?
In Singapore, not so, but I think the term polyps being loosely used, like the term sinus, is where we get that impression.
Yeah.
The turbinates. Let's look at slide number 6. So the turbinates are these structures at the bottom of the nose, and they stretch all the way from the front up to the back, and they're there to warm and humidify the air. Now, when they get swollen because of allergy, for example, maybe can you see slide 7? And it's congested, and it can sometimes look like the lower picture there looks lumpy and look like a polyp. And the reality is that without endoscopes, when you look in the nose, all you can see is this. So just by statistics, the highest chance is just a large turbinate. But yes, there is a condition called nasal polyposis, and we can go to slide 11. And in nasal polyposis, the condition is very different. This is not a condition of the nose primarily, but it's of the sinus lining. And you get so much swelling over a long period of time that it becomes permanent. These structures didn't exist before, not like the turbinate. They came from the flat lining of the sinus, and eventually they grew because of an inflammatory problem. And if you look at the CT scan on the right side, the central part of the nose is all gray. There's a lot of gray. In a normal person, all that's black because it's air. So nasal polyposis is quite a different condition. Treatment is also very, very different from treating a blocked nose from turbinate.
Right.
I'm not sure if you want me to elaborate on nasal polyposis, which is what I'm very passionate about. It's not one of the
more common.
easiest ones. I think it'd be nice to talk, because the moment we bring up nasal polyposis, a lot of people are very patients through the grapevine are very pessimistic, because they say, oh, you can't treat that, and you can't treat that with surgery. Or I've heard of someone who did surgery, and not long later the polyps all came back. So what's the point of doing it? Well, there is a point to treatment, though. I do agree with people who have that pessimistic view that historically it's been difficult to manage. And the reason is this: the concept has changed. In the past, it used to be polyps are just an extension of bad sinusitis. The holes are blocked, pus cannot get out, the thing gets swollen, and if you just drain the pus, take out the polyps, everything will be all right. But over the last 10 to 15 years, hundreds and thousands of research papers have gone to show essentially the polyps are formed because of an imbalance in the immune system, something like allergy, but a bit different. And so even if you do all that I said, draw out the pus, make the holes bigger, let the air go in, if we cannot control the underlying immune dysfunction that's going on, then the polyps will naturally grow back. And so that's really changed the way we address polyps these days. Now, the idea is not just to remove the polyps and forget about it. The idea in broad terms is to make the sinus space as big as possible inside, so that we can give washes, so that we can give nasal steroids, or steroids that go into control what's happening inside. And with that approach, instead of having a failure of maybe 80%, we now have a failure rate, or we now have a success rate of about 80%. So it's turned the table. It's not entirely foolproof still, but we did there.
But one of the more a cause for concern for polyps is that they can be cancerous as well, right? Like they could be is it a situation that precedes cancer? Like, do they?
The good news is that they don't.
Okay.
It's just that when a condition starts and it only looks like a lump in the nose.
Yeah.
And then then there's the confusion there. But a cancer starts as a cancer. A benign papilloma, which is the most common benign tumor in the nose, can look like polyps if you're just looking at it in itself. And over time, if it's left for long enough, a small proportion can become cancers. But inflammatory polyps in themselves, they don't become cancers. Very different condition.
Okay.
So I think that's one good thing.
Yeah. Okay, so coming back to the earlier question from the from one of the listeners about the two-hole syndrome, she's kind of mentioned that it's actually a maxillary sinus.
Okay.
Yeah. So can you just tell us what a maxillary sinus is?
Okay, the maxillary sinus. So the sinus of the maxillar bone, which is the cheekbone, that's what we call the maxillary sinus.
Okay.
So now I understand what she's talking about, two-hole syndrome. Now, the maxillary sinus has a small opening to come into the nose. And the thing about sinuses is that they're not just holes with no function. The lining actually has got cells with little hairs on them. We call them cilia. And the cilia beat to bring the mucus along. So mucus doesn't flow by gravity or anything. It basically flows because it's been drawn there by this beating of the cilia. And of course, the way our Creator made us is that the cilia beat towards the hole, which is naturally there. So unfortunately, sometimes there's a situation where there can be two holes. And so what happens is that cilia brings the mucus out through what we call the natural opening, which is right in front. And then as it comes out into the nose, some of it finds another opening and drops back into the sinus. And it keeps going round and round in that area. So it makes it harder for the sinusitis to resolve. So is FES the only way? Well, actually, now that I understand the question, the only way to resolve this issue is not medications, not anything else. That basically connect the two holes, make them into one big hole, and then it will function properly again.
So the intervention is necessary.
A small surgical procedure is required to do that.
Okay. All right, thank you for that. Now we've got quite a number of questions that have come in. One's obviously just asked. One of them has actually asked us a question that we talked about earlier. She's got a 4-year-old who sneezes every morning and has runny nose, but is fine in the afternoon till evening. So I think you mentioned that this is more a result of an allergy versus a sinus, right?
Yeah, most likely it is.
And are there any treatments? In fact, I think many people have, would obviously try to avoid seeking medical attention unless it really requires it. So maybe are there any sort of home or natural remedies that people could do, especially with these situations that surface regularly?
Yes, definitely. And I know that a lot of parents have concerns, firstly, about giving their young children medications. A lot of patients have concerns about the word steroids as well. So I'll cover that later. But I'll go in order. Yeah, so it depends on the severity as well. So there are simple things like saline sprays, which you can consider basically harmless. And the saline spray actually does I've tried this on myself, so I know how to describe this thing. So it doesn't just wash mucus away. The saline actually, for some reason, causes the congested tissues in the nose after a while to decongest as well. So it helps to make the nose less blocked. It helps to clear mucus. There are actually studies that show that it actually helps that process of transporting mucus in the lining of the nose as well. This is what we call the mucociliary transport. So just saline in itself is useful. And there are obviously pre-mixed sprays that are very convenient to use and also mixed to the right concentration. Because again, if you want a cheap option, yes, you can mix salt and do it by yourself. But if you want something that's really comfortable, we use the isotonic form. So that's the same concentration as our body fluids. Now, that's why when we go get water in our nose in the swimming pool, it doesn't feel nice because that's not isotonic. Our body recognizes that as a different concentration. It's not something that it wants to accept right away. Now, going on to nasal sprays in general, from the age of 2 onwards, there are nasal steroid sprays that are safe to use. And so when we talk about a child now, are nasal steroids dangerous? So when I say they're safe to use, there have been many studies done to show that the amount of steroid in the spray is so small that our body's own system for detecting and controlling steroids cannot even detect it if it's used in the right amount. And there are many studies that show that it doesn't affect the child's growth as well. So they are safe to use in the doses that are recommended. It's probably beneficial because if you think about it, there's almost no significant side effects from using nasal steroids. There are, but the same as placebo, so it's hard to say whether it really was from the steroid. But if you think about a child on the extreme who is now not sleeping well, getting sleep apnea, not concentrating in school, the jaw is not growing properly, the teeth get crooked by the time they're 10 or 12, I think it is quite innocuous or quite pretty. It's worth giving a try, nasal steroids. And then at the very most, I've got this advice for people: try it for 2 or 3 months. Then you decide whether life is better with or without it. And if you think life is better with it, start to reduce it to a dose which is the minimum that you can keep so that your life still goes on as good as it was when you're on. So I think that would be a nice balanced approach.
Okay. And yes, and then of course, the other question that someone else had was about asthma. Are nasal obstructions more prevalent in asthmatic patients? Are they interlinked? Does one cause the other?
They are interlinked. It's hard to say if one causes the other, but this is what we say: nasal allergies, they're not life-threatening. You can almost never at that stage. But with asthma, a small proportion of patients who've got severe allergies then go on to develop. We call this the allergic march because it seems to march from the upper airways downwards. And so many studies have shown that if you haven't developed asthma yet, and you control the allergy, then those patients are less likely to develop asthma as they move forward. And the same information and confirmation of that approach, I was going to talk about a cure for allergic rhinitis. So there are potential cures using immunotherapy. And those studies definitely show that if you control the allergy when it's still in the upper airways and don't let it go down to the lower airways, then you have a less chance of developing asthma. So they are linked, they are related. The changes initially are the same, but unfortunately, asthma can develop into its own monster once it's become well established.
That's right. Okay. Great. So now let's take a step out of out of rhinitis and move to sleep apnea, because you did mention at the start that was one of the areas that you focus on, and we noticed that sleep apnea starts from a very young age. So there are kids who actually suffer from sleep apnea, and then obviously it develops in adults at a later stage as well. So can you just briefly tell us the causes of sleep apnea?
So yeah, it's good to talk about sleep apnea because this is the one that really has consequences in the long term. And I think it'd be best to talk about sleep apnea in children as one thing, and sleep apnea in adults. Because sleep apnea in adults is it's much more complex and much more difficult to treat. So when we talk about a child with sleep apnea, first of all, is it important? Well, yes. The thing about children with sleep apnea is that they, instead of feeling sleepy, studies show that they actually a lot of them are hyperactive. That's how they manifest their sleep disruption. And for Singaporean listeners, there was a study that came out from, I'm not sure if it's KK or NUH, I apologize for not remembering, but they actually went to look at what parents might take notice of. They looked at how it affects their studies, and obviously they showed that sleep apnea causes a decline, or it's detrimental to studies. That might be something to convince parents. But moving aside from that, in children, the usual causes are, as I talked about before, adenoids, large tonsils, and sometimes at different age groups, the nasal turbinates. So in children treating sleep apnea, if they don't respond to medications, then many patients will go on to have their tonsils or adenoids removed. And that solves the problem for at least 80 to 90% of children who have sleep apnea. That's for a normal child. When it comes to adults, there's a big difference there because they usually come insidiously. It's like, oh, I'm getting older, putting on weight. Everybody around me also snores. So why is my wife complaining about this? I just do it. Shit. I know women snore as well, but it's usually the men that have a bigger problem at an earlier age. And so a few of those things come in. Yes, you can blame it on putting on weight, definitely. You can blame it on age. Yes, definitely when you get past 50, 60 and the muscle tone in the throat is getting less, that's part of the thing. But we often see a few other things. There's crowded, the throat looks crowded, the nose is all blocked. And I just want to then narrow on the simple part of snoring and sleep apnea. Now, a lot of people may not realize this, but when you're sleeping, the only correct way to breathe is with the mouth closed, that is through the nose. It is studies have shown that if you have the mouth open, even in a normal person, the resistance in the airway becomes increased a lot. That means you need a lot more effort to breathe in air. So therefore, the nose has to be clear. And it's like, I tell my patients like this, I'm going from point A to point B. I can take the old windy road, which is slow, or I can go by the new highway. Now, the moment the mouth is open, the tongue falls back, it is like you choosing to take the windy road. So there is only one correct way to breathe when we're sleeping. It's entirely different. People find it hard to understand because when they're exerting themselves doing exercise, of course, you open your mouth, try to get more air in. And that works because at that time, our muscles are holding open the airway. But when you sleep, everything's all relaxed. So opening the mouth just makes things worse.
Yeah. So with that, can kids actually forget to breathe, like in their sleep?
They don't forget to breathe, no. The moment our body realizes we're not breathing and the oxygen level drops down, it disrupts us. It makes us, it wakes us up from deep sleep to shallower sleep. We may not fully, be conscious, but it just disrupts the sleep so that the muscle tone increases and the airflow continues again. And this could go in adults. We have an index, the easy one. A lot of people do a sleep test. We'll look at this index and what is that number? That number is essentially the number of times per hour that their breathing is either blocked for more than 10 seconds or it's disrupted for about 10 seconds. And sometimes you look at a number and you say, oh my goodness, it's happening every 2 minutes or 1 minute. It's like you holding your breath for 10 seconds every 2 minutes or something like that. So,
but with snoring itself, like in adults, right? Because it's one of those things, like, because you mentioned it, it's so common. People wouldn't want to seek medical treatment for snoring, but what is the risk of letting it be there?
No, okay. So the risk is really a cardiovascular risk. Now, since in adults most of the time, let's say they've got an average build and they've been putting on weight. So sometimes, of course, you get the whole metabolic syndrome coming together. They're getting hypertension, they're putting on weight, they're getting high cholesterol, and maybe getting diabetes somewhere along the way. And so you don't know which of these is eventually going to lead to the final endpoint. But just physiologically, when we have sleep apnea or snoring, and we have to, it's easy to understand. Your chest, you need to exert a greater suction or breathing pressure to get the air through that narrowing of the obstruction. Because the heart also lies in the same chest, it has to pump the blood at a higher pressure to get it around the system. So we'd imagine that when you're asleep, you're supposed to be resting, but the heart actually working quite hard. And gradually what happens is these people develop borderline high blood pressure, then they get high blood pressure, and that then starts the ball rolling, because 10 years later, they are more likely to be getting cardiac disease, and 20 years later, they're more likely to be getting microvascular strokes, and which leads to dementia and loss of function earlier in life than they would have otherwise. And although this is not probably well known, a lot of people, when you do an MRI scan, see a lot of people getting scans for many reasons these days, much more easily than they did 10 years ago. And you look at the brain scans and you can see these microvascular changes. And what do they represent? I think the feeling is that they represent microscopic strokes. And just like the stars in the sky, they keep shooting out little strokes over the years. And that contributes to the decline in function. So a person who is very lucid and active at 90 years old, versus someone at the age of 72 who is already, not as clear-headed as he was before and slowing down. So I think if we put this in context, it's very hard for patients to see themselves 20 years later.
Yes.
But I've seen enough patients, close friends and family to understand that there is a relationship there.
Right. But then, like for someone who wants to resolve snoring, is medical intervention the only method, or like do these, these over-the-counter nasal strips, do they work?
Now, for the lucky patient who has not built up any weight around here
Uh-huh.
and who has good configuration behind in the jaw and only the nose is blocked, maybe the strips work. Maybe at that early stage they work, because especially for people who have very narrow nasal profile, that could just open up the nasal valve. And
Okay.
so for a certain small section of people it work. But the typical patient that we see who is 50 years old, actually probably the most non-medical thing that they can do to help themselves is to become as skinny as they can possibly do. But the studies show that even if they did that, they would never be as good as they were if they have never put on the weight before. But definitely weight loss is one of those things that we get them to do.
Mm-hmm.
And there are some other non-surgical interventions to improve the situation. There are anything that can get the tongue to come forward and stay out of the way of the throat, and it can help. So there are professional things that are made by orthodontists where it fits your palate perfectly and suctions the tongue forward, it pulls the jaw forward as well. There are things that those are expensive, custom made, but easily now on the internet you can get things that fit just like that, and they, if someone uses them, they will help to some extent, but they only help the milder cases. If it's severe, you've got many other factors going, that's not just going to do that alone. So in that situation, the other non-medical thing, I don't know if people consider it medical or not, is a CPAP device, or a positive airway pressure device.
Yes.
Which keeps the airway open as you sleep by applying a bit of pressure there. And
Yes.
so those are the non-surgical interventions. Any surgery that is done for sleep apnea has got just a few objectives, whether it's applied in the nose or the throat or behind the tongue. It's there to open up the airway to make it as big as possible, or it's there to tighten it so it doesn't collapse as easily. And there are various different surgeries and different combinations, and it depends on what factors are at play in each person.
Right. So when you talk about these non-surgical methods, do they actually help to manage the situation like there, or does it just arrest the problem, or does it sort of resolve it over time? So meaning like over time, you don't actually need any intervention. Do the symptoms disappear over time?
I think this one is easy to understand. I think people have a lot of hope that they do something and it will go away.
Yeah.
But it's a structural thing. There's a structural part and a functional part. So if the structure doesn't change, then without that intervention, like the CPAP machine, you put it on, but you have the same weight, your nose is just as blocked, then it's not going to change.
Yeah.
Potentially, on the milder stage, if you think that you can improve your tone, just like when you go to the gym and improve your muscle tone, if you could improve the tone in the tongue, the cheek muscles, and the throat, and the mild end of the spectrum, then you have a chance. And there's new research coming from some of the top centers in the world on myofacial treatment, essentially how to increase the tone. And I think that's encouraging. So especially with I'm seeing a lot of patients now where they're more aware of these things. They're putting on they buy their own little things to check their sleep.
Yes.
And they're catching these problems at an early stage.
Yeah.
And so those people going for these sorts of interventions may be helpful. But traditionally, the ones who come already at the severe end, these things are going to be hard to work. And it's very hard to get, you can imagine this, if we tell people that you need to lose weight and go to the gym and all that, if you have to tell them to do some exercises in the mouth, I think the success rate is just not easy to achieve.
Yeah. But of course, do you recommend like a sleeping position, or does it not matter? Like, is snoring actually like caused by a certain sleep position, or not?
I beg your pardon, snoring causes?
Yeah, like as in, is there an ideal sleeping position that you can take if you want to avoid snoring?
Oh yes, that's true. Just by gravity, if you're lying flat on your back, then the tongue's more likely to fall back. And this is what we see in the sleep studies that we run, because it checks your position. And almost always the score is worse when the patient's lying on the back. So if you can force yourself to lie on the side, one side or the other side, you're just going to improve the situation. It may not cure it, except in the very mild cases where it's very positional. But that's worth trying. Just the only thing is that how do you enforce that when you're sleeping?
Yeah, exactly.
There's been all the now there are better things, but the original trick that was done in the old days was to get someone to sew a tennis ball in the middle of the shirt so the person could never lie on their back comfortably.
Or like, I mean, I remember when I was pregnant, like you just had the belly as a deterrent, right? So you would just sleep on the side inevitably. Yeah. Okay. We've got another question from Facebook about nosebleeds in children. Just wanted to find out, like, because we do see it as a common problem among kids, especially in primary school. And it tends to become a bit of a social problem if the child is experiencing nosebleeds often in school. So, what are your recommendations to deal with it?
Well, my recommendation first is always to have it checked to find out what the cause of the nosebleed is. Yeah,
Okay.
but well, 99% of the time it's going to be the same thing. But there are conditions, and especially in adolescent or male kids, but it doesn't only happen in males, but usually there can be a tumor of the blood vessels that can cause a lot of heavy bleeding. So you need to have it checked out first, and that would probably be involved doing a scope. But by and large, most patients who have nosebleeds of that age group, they're getting it from somewhere in the nasal septum in the first 2 centimeters of the nose. And essentially, it's this: you've got a lining that ideally needs to be moist and needs to be healthy without any crusting. Now, when you start to get dry mucus on a certain area, kids they don't like that. Kids like to pick their nose, blow their nose, and if you keep doing that, imagine if you've got a cut, a skin wound, and every day you keep peeling off the scab, it never heals. And what happens is the tissue underneath becomes more and more irritated, vessels become bigger, and then you get repeated bleeds coming in. So the the thing is there's first aid management. We may talk about it later, but there are a few other things. So if I see a patient where that lining is just a bit excoriated, maybe there's a chance to nurse it back to health as you would nurse a wound. I get them to spray the nose and keep it moist as often as they can. Never to pick the nose. Don't go blow super hard to get the snot out, but usually to soften it up and let it settle down maybe over a few weeks. But if it's recurrent or if there are already vessels that have grown bigger because of all that recurrence, then we may have to cauterize the nose. We do that either with silver nitrate or bipolar cautery, depending on the patient. Now, in some patients, why is it that one side always bleeds? And the thing about the septum is that I showed you a diagram of the septum that is perfectly straight. Almost none of us have a perfectly straight septum. It's usually bent a little bit one way or another. Now, the more bent it is, it affects the flow of air, just like the wing of an aeroplane. There is more drying effect on the side that is convex, and that's where the crusting tends to build up and the bleeding. So if that is, some patients ask, can I reduce the risk by straightening the nose? I would say there's a good chance, but that's not usually the reason why we straighten people's noses inside. Often, again, going back to the question about kids, and sometimes they have upper respiratory tract infection, flu, or allergy, and if the allergy is not controlled, then you're getting abnormal mucus, you're getting more congestion, more inflammation around that area, and the nose is just generally more irritated. So at the same time, if they have allergic rhinitis, then I'd advise to get that managed as well, so that you can optimize the conditions in the nose. Is there anything else? What about first aid? This one maybe is really, really important. Now, I know that people press the nose in different places. Now, let's say we're assuming that 99% is all in front here. So if you apply pressure on the bleeding point, it should stop. And therefore, when people get a nosebleed, they shouldn't be pressing up here where there's a bone. There's nothing that you can do up here except cause pain through the skin. But here, the soft part of the nose, that's where they should be holding the nose if they're trying to stop the bleed. If the bleed is not there, holding the nose there is not gonna do any harm.
Yeah.
The other thing that I advise is that rather than tilt the head back so that you don't see blood coming out, it's better to have the nose level or down. It's okay to see blood coming out. It may scare everyone else around you, but it's good because you know how much blood coming out. If you do this, you don't know what's going down. Maybe it's swallowing the blood, and at the very least, the whole nose gets clogged with a clot about that long. So sometimes when I see patients who've had nosebleed, and you pull out this thing and it's a big clot, and then they get another shock. Wow, so much blood in the nose. That could have been minimized if they just held the head down and pressed the soft part of the nose.
Do you so they're not allowed to blow? You don't encourage them blowing the nose, right? Because that's more pressure on the.
I don't encourage them to do it when it's bleeding or soon after the bleed. Now, maybe 1 hour has passed after the bleed, everything kind of settled. At that stage, I would probably say when you want to get the clot out, spray with saline, let it loosen up first, and then when it's loosened up and you can blow lightly, maybe that's the time to get rid of the clot, but not earlier than that.
Okay. We've got a COVID-related question, Doctor. So the question here is actually about some patients recovering from COVID experience hard breathing. Is there a way to relieve this?
They experience
hard breathing.
Hard breathing.
I mean, I suppose they have difficulty breathing.
I guess that has to be assessed in its own right, whether they had COVID or they didn't have COVID. The hard breathing may be just nasal obstruction, or maybe actually what's happening is that the airways are all maybe the capacity. If the lower airways of the lung has been affected, then they're going to have hard breathing. So it's hard to know. And we often face patients who come say we're short of breath, and sometimes they really are short of breath, and it relates to asthma or something else. But if I say to them, hey, if you open your mouth and you take a big breath in, does it feel better? And they say yes, and the problem's likely to be out here. And I can appreciate that when we are sick, our nose is all blocked. It just feels like it's harder to get air in. This feels very comfortable.
Yeah. Okay. And we've got a question here about nasal obstructions causing foul smell. Is there any? Yeah, it's possible.
Yes. Nasal obstruction is one of the symptoms of sinusitis. So the simplest answer to that is that if you have sinusitis, and you can imagine that you maybe a big sinus here, you get a tiny hole, 1 or 2 millimeters, and you can't get all that stuff out. So all the mucus in there, apart from being infected or inflamed, has been stuck there for a longer time than what you expect. So it's getting stale. Its smell is bad. So that's probably the most likely explanation. There are some rare conditions where the nose itself has got an infection. This is not common in Singapore because it's humid here. In some dry climates, you can get a certain kind of condition where you get a lot of crusting in the nose related to a certain type of bacteria as well. In that situation, it can be very, very foul smelling. So both of them eventually cause nasal obstruction as well. So in that sense, they are related. But it's usually related to mucus being stuck for a long time, infection, whether it's in the nose or in the sinus, which is more common.
Yeah. So I've seen people who've actually, with nasal obstruction, and obviously it bothers them so much, and then there is this urge to either try and really blow hard or induce a forceful sneeze. Do these things actually help? Or are they just providing temporary relief, and then in the long term, is it more harmful? Does it do more harm than good?
If there's a lot of mucus there and you can blow it out, that makes sense. And we all know how nice it feels to get that out. Yeah. But if you've been blowing and then nothing's coming out, then it's probably not going to be helpful anymore. That probably means that the mucus is stuck in the sinuses and you can't blow it out, or the lining of the nose itself is congested, and therefore, as much as you want to blow it out, it's not going to come out. Was there a follow-up question to that, blowing your nose? I think sometimes in that situation, if they've got nothing else, you've got no medications, actually a nasal saline spray works very well. I mentioned that earlier. I've done this on myself as well. So I've tried all these things on myself before I tried to advocate them, apart from being backed by studies. And I know that can help. You just got to be patient.
Okay, so I think we're doing really well on time. We've got maybe just the last 5 minutes, so maybe a couple more questions. These will be your last couple of questions, Doctor. Yes, about sensitive nose. So someone's actually asked, is sensitive nose resulting in a daily forceful sneezing amongst the elderly?
It's not common to get allergic rhinitis in elderly.
When you're old.
Or they tend to wind down by the age group. And I guess there's a change in the immune system. So, but there are people who get still allergic rhinitis in their 60s and beyond. No, it's not common. It's not common to do that. But I got to say that sometimes over time, people can develop the need to sneeze or force something out to feel better.
Yeah.
So it's just like you click your arm, you crack your knuckles, that kind of thing.
Yes.
That may have become a habit. So objectively, there may be nothing to sneeze out again.
Yeah.
Okay,
So the final question.
Actually, I wanted to just show the difference in, because there was a question about FES just now, and just related
Yes.
to holes. Can you bring up slide 12? And this relates to the polyps again. Now, I just want to show a situation. Now, the picture on the left, nasal polyps. Actually, this is a patient who has had a previous operation, and as I mentioned before, a lot of people have pessimism because it came back. And the reason was the concepts in the old days, or if you use a concept where we just open a hole and drain pus and remove polyps, that is usually not going to work. The surgery itself is a plumbing job. So look at the picture on the right side. With that one view, we are able to see almost everything in the sinuses. There are no more hidden corners. In that one view, I'm looking at the top, at the sinus above the eye, the one that is at the skull base, and the one that's right at the back. And if we could look to the right side, we could see a big hole. We can't see it here, but if we see a big hole in the sinus. It is that kind of cavity that we need to create so that when we spray, when we wash, that medication reaches those areas. Otherwise, if we just have a hole that is 3 or 4 millimeters, whatever we spray or wash is never going to reach those places. And that's one of the key messages that I've been talking a lot for the last 10 years about how that's the only way right now that we're going to have some control over nasal polyposis. Sorry to digress, but I just
I think that's useful. Yeah, the visual always helps. Yeah. Okay, we've had one more question that's come from Facebook about balloon sinuplasty. What is balloon sinuplasty, and will it help me in my nasal obstruction?
This is the perfect time to talk about this, just after I brought up nasal polyposis.
Yeah,
so
exactly.
Balloon sinuplasty is a way for opening up the sinuses to a certain size, and that's what it does. And so now, which patients would benefit most from this? Now, if all you needed was to suck out a bit of pus and create a wider hole, and after that event has settled down, everything is okay, balloon sinuplasty would be one way to do that. And especially if you could do it in the clinic, in your office, when you're awake, that would be the greatest benefit for a patient. Now, if you had to go to the operating theater to do that under anesthesia, then there are different ways to open up the sinus to far bigger than the balloon can in many patients. So the balloon's got limited size, maybe 4 or 6 millimeters, depending on what you choose. And in the surgical procedure, you can make it as wide as the patient's anatomy allows. So balloon sinuplasty, if used in the right setting. Now, I've used it, for example, in a very old patient who, if he went to anesthesia, that would be a risk for him. And all I needed to do was open up that sinus, get out a bit of pus, flush it a bit, and 1 or 2 weeks later, it's okay. Avoids taking antibiotics. That's a perfect situation. But I don't use it when I do it FES in the operating theater when a patient's under anesthesia, because they are often polyps patients with a lot of debris, multiple sinuses. The balloon's not going to create that big cavity that I just showed you just now.
Yeah.
And it will never create that.
Okay.
So I think balloon sinuplasty has its place when it's chosen, when you choose the patient and the condition well, has its place, but certainly it is not equivalent of FES. It is just a tool for reaching certain parts of the sinus system. And the other thing that I got to say about balloon sinuplasty, it targets the main sinuses. So imagine this: you have a big complex. You've got the frontal sinus, the maxillary sinus, and the sphenoid sinus. So the balloons are designed for those sinuses. But we don't forget that around these sinuses, there are other small sinuses. So if you've got widespread infection and you open the channel to the main one, yes, you're treating the main thing, but potentially you're closing up small little corners where the problem can persist. So I'm not for or against it. I'm just saying balloon sinuplasty in the right setting. And for me, that would be someone awake in the office, small problem, wants to avoid taking antibiotics for 3 weeks, 6 weeks, just to get over an infection. That would be an ideal patient for that.
Right. Okay. Thank you so much. So I think we've come to the end of this session. It has been a very informative session for me personally, Doctor, and I really want to thank you for your time with us this afternoon. We really appreciate you sharing your valuable knowledge. And I think we've had so many interesting questions that have come through the chat, and and I have learned a lot about new conditions affecting the nasal passage. So it's been all good for me. Now, there are still questions that are coming through, and some of you may feel that we may not have answered all your questions due to time constraints. But if you do have a condition or a query, I'm sure Dr. David Chin at the Ascend ENT will be more than happy to take your questions after this through email. The email address for Ascend ENT and Mount Alvernia Hospital is on the event banner. So please do reach out to him. As just to summarize what he said, obviously don't leave things to the advanced stage, because when you treat something early, or when you've addressed it early, it seems just based on his experiences that there is a better outcome. Is there anything else you'd like to add, Dr. Chin?
No, I really appreciate that you've covered so much, and a lot of the questions have been really, really appropriate at the right time. I think I've touched on everything that I really wanted to touch on, and I welcome any further queries. I'm happy to answer them. And at the end of this, if you want to put up slide 15, they can actually use the QR code to get to our website, and you can see that. So thank you very much, Seema, for hosting, and for the rest of the team for facilitating this. And
thank you. Yeah,
to everyone.
This is the QR code that you can scan to get to contact Dr. David Chin. In the meantime, I would like to wish all of you a pleasant weekend and stay safe. Till the next time we meet, this is Seema signing off from you. Thank you and stay safe. Bye-bye.
Bye. Thank you.